And COVID was such a challenge for us. I mean, in so many aspects, and it's one of the reasons most healthcare professions were able to identify. We were challenged to point out the dysfunctions that have been there in the health system. And for us, I know I speak for people who practice in the hospital pharmacy. I know we've all practiced there, and one of the major challenges we were really experiencing is the transfer of medication from the pharmacy, because the nurses will have to come to the pharmacy and pick drugs, then take them back to the isolated area that we created for the COVID patients. So they come to the pharmacy, they go and gown and again take the drugs to the patient, and if at all the patient needs some more medication, the nurse also still has to change again and come back and take the drugs again. And so trying to avoid that contamination between this clean and dirty area room, so to speak, was quite a challenge. And that is what inspired this idea in Dr. Njao and Dr. Mdhoni. So it's called the automated dispensing cabinet. It's really not a new idea. It's been there for the longest time. And it started back in the 1980s, actually. So there are several formats that I'm going to exist currently in the world about the dispensing cabinets. But in this presentation, we mainly focused on the decentralized system. So there is a centralized system that I'll just point out briefly, whereby each patient's bed in a ward has an attached this automated system, and every nurse, every caregiver that is at the point of care of the patient can be able to access that. But then we are a growing country still, third, second, and like I said about growth, we don't have, it's going to have to be gradual. So even when I stand before you guys, for me, since you are way experienced than me, I always take it as a chance to learn. So I think let's look at this as a way of brainstorming how we can further refine this system so that it can work. We can tailor make it for our country, and then slowly we can start to advance it. So the automated system, in simple words, how I can best explain it, it's a system whereby there are closed cabinets, yeah? And these closed cabinets, especially in the wards, they're usually these, some are even built by wood, others are just cabinets, the typical cabinets, the wood made, that kind of, that's what has been used in the past, whereby the nurse, when they pick meds from the pharmacy, that's where they store them, yeah? And they are not secure and safe for all the medications. I mean, it's accessible to anyone that needs to take the drugs, for both the caregivers, even to the patient sometimes. So this closed system, the automated system, what it does differently is that it has an attached computerized system to it, yeah? An attached system computer, whereby when you feed it with information, like the user's ID, or you feed it with the information about the drug. For some systems, they have used the manufacturer's barcode. It gives you information. And these cabinets do not open until you've given it information and instructed it. Until then, this system remains closed the entire time. So I know how keeping safe of controlled drugs has been quite a challenge. So I hope we can already start to picture how this will be very convenient if you want to keep your controlled drugs safe. And I'm not going to narrow it down to just a hospital. I know some of us practice in the community pharmacy, and I can encourage us to think even wider and think how we can integrate this in our community practice. So as I said, also in the hospital setup, for all of us, I know one way or another we've had to practice in the hospital setup, and one of the major challenges that we experienced during dispensing is there is a lot of work, a lot of traffic, and sometimes you even have disruptions. As simple as a phone call is enough to make a difference between life and death decision for a patient, that the human errors. And so what this system we are trying to do, no, don't worry, it's not going to take away our jobs. It's really just we are going to co-parent. I am sorry, I don't know why I'm talking about family so so much, but it's going to make us more efficient. We are still going to have work as pharmacists. It's only going to make our work more efficient. So this is how, and in an ideal setup, how the automated system looks like. As I mentioned, it has cabinets, a setup of cabinets on them. This is how they look. Is it clear? Is it clear to everyone? Yeah. So, yes? Oh, okay. Oh, okay. The IT guys? Okay, while they work on that, I'll just continue to talk about it. So these are the cabinets. I don't know if it's universal for all the hospitals, but this is generally the setup. It just looks like your typical, maybe a crash cart, and I know maybe the designs are different for different hospitals. So as you can see in the other photo, there is a computer system that controls the dispensing of these drugs, and you are even able to track up to the point of care of the patient. So you log in your system. On this photo, right at on your right hand side, you can see a button. Yeah. So for this photo, it just shows the login using your biometrics. You put in your finger, and you are able, immediately the system starts projecting, it starts giving you information. And then once you log in, you are able to access the full patient's profile. Yeah, patient John Doe. This is the diagnosis that they have, and it just gives you all the information that you have on your T-sheet. It gives you the information about what is all the drugs that the patient is on, even the period. Just literally your T-sheet just transferred to that small gadget. And then as a nurse now that is going to dispense drugs, then they are going to just feed in the information, and then they are able to know the amount. Now as a pharmacist at the pharmacy level, you are in charge of all this. You are able to enter data for each patient for a specific ward. So how we were thinking about it is that each ward has one common room, one of these device. You don't for now as a country, when we are we are being realistic, we are not able to have for the centralized for each patient. So I was thinking we start from here. Yeah. So you have 30 patients in a ward. The nurse enters every information for each patient at a go, and then they are able to determine the amount of drugs. So here at the medium security, let's start from lower bit. The medium security, you have your antihypertensives, your antidiabetic, which are drugs that we mostly don't lose track of. I mean, we do sometimes, but they are not very drugs that are like the controlled drugs in comparison. So you have them there, and once you put in your details, only this cabin, only that part of the cabinet will open, exactly like this. It will open, and you'll be able to pick the drug. So this is for the medium. So you see, like the whole of it is open because these are medium security. For the medium security, so you'll be able to access for each drug. Another cabinet will not open unless you've entered the patient's information. So the password is, make sure you enter the patient's information, and their cabinet and all their drugs will show up. And then for the maximum security one, where we are worried about what if the cabinet opens and the nurse takes, or anyone that is not authorized, takes the medication of one patient and the other patient. Yeah. So to counter that, so I don't know if I'll have time to play a video, but for that, so each of the compartments in the cabin have a lid. Yeah. You have the compartments within the cabinet, but on top of them there's a lid. So when you open the cabinet, even if you're opening the whole of it, everything else that does not involve that patient will stay locked, and only the compartment that has that patient's medication is the compartment that will open, and then you'll be able to access their drugs, and then the others will stay locked until you've entered that specific patient's information. I don't know if I'm making sense. So here shows just a different designs, how you can tailor make it for your patients depending on the capacity of your hospital, of your patients. You can compartmentalize it really in different shapes, sizes, and all that. So what we are trying to do here, one of the gaps that we were experiencing is that as pharmacists, I can tell you, I don't know if I have people who have recently completed the internship like me, there was a lot of work. You have so many ideas. Like I told you, some of us have trouble sleeping because we are feeling like there's a lot of passion that is untapped. So you get home, but because you are drained so much, there's a lot of work at the hospital, serving each patient. Then you don't, you for the tracking of the medication, that is something you keep pushing, yeah? You keep pushing at the back. You say, oh, we'll track this during stock take at the end of the month. And at the end of it all, you don't even have the time. Like at the end of the month, when amlodipine, one tablet of amlodipine was missing, you are not able to capture that at that same time. So it will continue to pile up. And at the end of the day, these are losses to us and also the patient. So once the nurse has been able to access all this, actually the system also has things like alarms installed in them. If the person tries to access a cabinet that they were not supposed to access, for example, a high security, like the maximum security cabinet, the alarm will go off. Or maybe you are not concentrating, you accidentally open the wrong cabinet. Yes, yes. The patient is able to, the alarms will go off and you'll be told that you are accessing the wrong cabinet. So once the nurse is able to give these drugs, and information is sent to the pharmacy, us at the pharmacy point of care, and immediately we get a notification. We get a notification that someone has accessed patient A's drugs, and depending on how you've set up your system, maybe you will even have a printout. You'll be told, maybe if you gave like three tablets to these patients, you'll be told a tablet has been removed from the cabinet, there are 2 tablets left. So we are able to, the tracking of medication is literally within 24 hours. There's no pushing back work. You are able to keep track of everything at the point of the pharmacy. So in case there is any discrepancies, you are able to capture them in time. And if it's a controlled drug, you are able to know that the patient has gotten. I mean, we are not sure that maybe they took it. I know that's still a gap, but at least you're sure that the drug was accessed from the cabinet and the patient got it. So how, if you look at it, you start to realize the workload that, as a pharmacist, the core role of our career is to dispense. The 1 times 2 that we sometimes hate, that is our role. That is our role. So we don't want to get away from that and kind of like push that work to someone else. We are just trying to make it more efficient. So we'll have more time in our hands. Our skills can be used somewhere else. I know we want to feel one of the problems that we even lost our voices even in the wards is when we stopped being in the wards. When we started, the doctors forgot to feel our impact. You go to the ward rounds and all the doctor wants to know is the price of paracetamol in the pharmacy, or if you have anything. So once we have this time, then we can have more time to be in the clinicals. When you have ideas, the young pharmacists want to brainstorm ideas, you can have more time to think about ideas, to be in the research, so that we can have more impact. We can get our voices back, so to speak. And also, as we talked about the MTM clinics, we can have more time because, as I said, it takes a lot of time. The gap that we have in the dispensing area, we don't even have time to do MTM. So how to do this is integrating this into our systems. So some of the few gaps that we'll have, that a bit of gaps that maybe will inspire some future researchers, is that this system, you only have 1 cabinet, and maybe you need to serve 2 patients if, for example, it's an emergency. So 2 people cannot work on this cabinet at the same time. You have to serve 1 patient at a time. So that's a bit of a challenge. You can think of ways that we can, which of course it's the centralized systems, but it's also it provokes thoughts in us on how we can do better. And also a nurse or someone, a caregiver, may take the drugs and we are not able to know if the patient actually got, or a vial broke. We are not able to still track the information properly. So that's still ideas that we can really brainstorm for the future. And also the system also has a battery installed. In case you are wondering, there is a battery. The nurse unplugs it from the socket, dispenses all the drugs round to each patient, and the battery lasts even for up to 3 hours. And then after they are finished, I know it can take 3 hours to dispense just within a ward, you can go back and charge it. So even in the county areas, that should not be a big problem. It's something we should really embrace. And as I'm speaking, we don't have it in the country. And I know that I don't even want to quote the prices. We already have enough marriage issues. We don't want to add money. But the truth of the matter is it's expensive. It's quite pricey. It's quoted for up to 8 million per cabinet. But then, again, I'm thinking that we also have a pharmacist actually in our hospital, an intern. Again, I told you, it's like a factory for interns, that place. So he was involved, he's a student from KU, Kenyatta University. He worked on a project during COVID on the mechanical ventilator. So they are together with JQuat students. So they are going to refine this further, and maybe we can borrow from them to be able to just make the cabinets within our country, and then they can add this technology, the computer system, into it. And as you can see, so in the future, prospects show that we are going to have, the prices are going to go down. It's going to be accessible for all of us. So I really want to challenge us. If you want something so bad, like you want growth, even personal growth, even for our pharmacy, how far are you willing to go? How expensive can it be to just invest into something to make our career even better? Thank you very much.
Thank you so much, Daktari. I think that was a wonderful presentation. One more round of applause. I think we can see KUTRH, they are setting the pace in terms of pharmacy practice, and I think that is good. And I'm sure those of us who are practicing in other areas, that is a good challenge to us, that yes, we can improve pharmacy practice. Next, I would want to call upon Dr. Peter Mugo. You are going to get a chance of asking questions. We are really pressed for time, so just hold on. So Dr. Peter Mugo will present on the policy and legal environment surrounding HIV prevention through community pharmacies in Kenya. And so I want to welcome Dr. Peter to come and make his presentation. Dr. Peter, if you can make your presentation in 8 minutes, I will appreciate. We are really pressed for time. Actually, no. They have actually been loaded in the laptop in the main. Yeah, I don't think they have made arrangements for the breakout sessions. So they picked it. Just to break it. Yeah, these are not well configured.
I hope you can see the slides, and I think I'll have to stand here, so I hope I'll not block anybody. Good afternoon. My name is Peter Mugo, and I work at Kemru Wellcome Trust in Nairobi. I've been doing some work around pharmacy-based delivery of public health interventions. So today I'll talk about the policy environment and how supportive it is of this approach. And this is part of a larger project where we are looking at the implementation of pre-exposure prophylaxis and HIV self-testing in private retail pharmacies in 3 counties of Kenya. So this part of the study just looked at the policy environment in terms of documents, legal and policy documents. Very quick introduction. I think it's good to always remind us that HIV is still a threat. It's still an important disease. And this, I'm sure you probably can see it very clearly. So this graphic just shows the size of epidemics over time in terms of mortality, number of deaths. So the pink one here, the one that is circled, that is HIV. And the only other epidemic that rivals HIV, which is currently at about 35 million deaths, is the 1918 Spanish flu. That is the green ball there. So corona, I think this needs to be updated, but you can see corona is still a relatively minor epidemic. But I think that is because there was a very good response. Not because that the disease itself is not a threat, but the response was very good compared to, I think, what has happened with HIV and the Spanish flu of 1918. So in Kenya, we have 1.3 million people living with HIV, which is about 4.9% of the population. And every year, currently, we are having about 36,000 new infections. So we can say the epidemic has not been controlled. Control here defined as, bringing the prevalence below 1%. That is sort of the consensus of what we mean by control. So at 4.9, we still haven't controlled the epidemic more than 30 years. Is it 30 or 40 now, since it started? And this is despite the fact that we have highly effective interventions, including old ones like condoms, testing and counseling, mother-to-child transmission prevention using antiretroviral therapy, needle exchange for people who inject drugs, male circumcision. We have newer ones like what we are referring as U equals U. So basically use of ARVs as prevention. So diagnose people early, put them on treatment, have them virally suppressed. And it has been shown that when the virus load in the body is undetectable, then that person cannot transmit even if they don't use a condom. So I think that is one of the most promising one. And then the newest kid on the block is pre-exposure prophylaxis. So basically for those who are not infected, using ARVs regularly to prevent acquisition, which is also related to PEP. I think we are very familiar with this as pharmacists, so I won't even go into details. And then regarding all these, we have the structural interventions like stigma reduction, health system changes, and so on. So why we consider pharmacies, all these interventions can be delivered at the private, at the community pharmacy level, except perhaps circumcision and PMTCT. All these others, if you think about it, can be delivered. So that is the rationale of looking at what is the feasibility in terms of how supportive is the policy environment of such approaches. So we used pre-exposure prophylaxis and HIV self-testing as case studies. And the objective was to assess, as I said, the policy and legal environment and how supportive it is of the approach. And just as a background, so the policy context would reside in the, most of us are familiar with the WHO pillars for health system strengthening. So policies and guidelines would reside inside the governance, leadership and governance. And the purpose of policies and laws is to define responsibilities and relationships between the users, between healthcare workers and policy makers, that is, political and government decision makers. So it's very important, and probably that's why it's put in the middle, because without an enabling environment, no matter how well you try to implement certain intervention, you'll always find that there are challenges in adoption and mostly with sustainability. So you may do a pilot, you may do a scale up, but if the policy environment is not supportive, then you find that it fizzles out after some time. So in terms of what we mean by policies and laws, so policies are documents. They don't have to be written, but they can be unwritten. But basically, they outline what government is going to do or does not intend to do. So both sides of the coin. And these, the primary documents may then evolve into policy guidelines. So those will be the detailed implementation guidance. And policies are framed to achieve certain goals. And you'll see the difference with what we mean by laws. So laws are basically legal documents that are enacted by legislature, and they set standards, principles, and procedures that must be followed in society. So must be followed. While policy guidelines also sort of mandate action, but they are more suggestive rather than prescriptive. So laws would be administered through the courts, as you've been hearing in the main session, how PSK is doing very well on that pillar. So in terms of methods, we basically looked at documents that we felt are relevant to the research question, and we asked key informants about this, and also based on our previous work, we identified documents, and then we also did a web search. And then the documents that we found, we also looked at the reference lists, and then we also looked for those that we felt are relevant for the review. We then extracted basic information about the documents onto a spreadsheet, and then categorized them in terms of the type of document and the level of support. So level of support was in 5 levels. I'll explain on the next slide. So the documents that we felt are the most supportive would be what we call explicitly supportive. So these are documents that recognize pharmacy delivery of HIV prevention as an appropriate or effective approach. And then we have those that are just supportive. They don't mention pharmacy delivery specifically, but they contain statements on the need for innovative delivery models or recommend structures that would be supportive of pharmacy delivery. And then there are those documents that, while they would be expected to address the issue, they don't. They're silent. They're silent on it. And then we have those that are mixed, so both a bit supportive and a bit restrictive. And then we have restrictive would be documents that contain specific statements that restrict or discourage pharmacy delivery. So on to the results. In summary, we found we reviewed 57 documents, and 27 of these were deemed to be relevant and therefore are included in the summary. And of the 27, about half were supportive. So this is good news. And even, well, you'd expect maybe it was 80%, but 50% usually is considered a pass mark. And then when you look at key documents, so those would be the ones on the left, the one with the dark green. These will be the higher level documents. So the laws, the policies, strategies, and guidelines. You can see 22 were supportive. So I'll give examples. I don't know if I still have time. So this is just for illustration. Most of us have interacted with these documents, so I'll not go into details. I think the slides will be shared. But basically, in terms of the high-level documents, the ones that were explicitly supportive was just this one here, which is HIV and AIDS Prevention and Control Act. Now, this act specifies who can provide HIV testing, for example. It includes pharmacists or those who are registered under the CAP 244. And then we have guidelines. So these are our primary documents. So we have the HIV self-testing guidelines and the pre-exposure prophylaxis guidelines. So both of these documents explicitly state that pharmacies are channels for delivery and identification of users of those interventions. And then we have so guidelines that emanate from the primary documents. So we have these, the blue one here. These were guidelines that were specific for pharmacy delivery of HIV self-testing. I do not think that they have been launched. So they were developed, and then the person who was championing that, I think, left, and that sort of fizzled out. And then we have the HIV and APNS document guidelines, which is sort of a revision of the 2017 document, including assisted partner notification services. And then we have guidelines that are supportive, including the an interesting document that I found, the pharmacy specialties. How many are aware about this guideline on pharmacy specialties? It's a very interesting document, and it is, we consider it supportive because it talks about specializations that would be considered public health. Okay, so hopefully these will become regulations within CAP 244 at some point, or the new Pharmacy Practice Act, because it's very supportive of public health delivery in the pharmacy. This one is again a very interesting one. Task sharing policy guidelines. It talks about, and I found this quite interesting. So it talks about what public health sector pharmacists and pharmaceutical technologists can do, and you can see it's almost all the HIV prevention services. It doesn't talk about community pharmacy, but you can extrapolate and say if pharmacies in the public sector are able to do this, then even in community pharmacies, because they are, I mean, the training is the same, they would be able to do that as well. So I'll not go through these ones, as I said, because of time. Let me see if there's one that I would like to highlight. Yeah. So we had 13 silent documents, and that is the list. The one that I would like to highlight is CAP 244. Currently it is silent. It doesn't talk about, you know, this kind of approaches. It doesn't talk about public health, which I think is a gap. I hope the Pharmacy Practice Act will address that. Great. So, okay, let me highlight this last one. So this document is mixed because while it recognizes pharmacies as point of identification of users, it stipulates that the PrEP must be prescribed by a clinician, which would then restrict, you know, a program where we would have a one-stop shop for that service without clients having to go somewhere else. So in conclusions, 50% of the documents we reviewed were supportive, and we found that testing was more supported by the policy environment than PrEP for reasons that we can discuss during the open session. And then a key finding also is that 50% were silent, including CAP 244. And this means for these silent documents, there are opportunities for improvement over the policy environment. So as policies, the hope is that once we share these, maybe in our policy brief or something, with PSK, Ministry of Health, that when these documents are being revised, then these ideas would be considered and added in the documents. So thank you very much. I would like to acknowledge the funder and my collaborators. Thank you.
Thank you so much, Dr. Peter Mugo. I think that was a very insightful presentation. I think trying to look at those policies and laws that regulate maybe some of these issues around HIV. I think that was a very nice presentation, and we can do better by giving him another round of applause. Next, I don't know whether Dr. Wambulo is here. Dr. Wambulo? So I think we are going to have Dr. Orangi, and Dr. Gavin Orangi will be presenting on the effects of antimicrobial stewardship interventions that is implemented in a rural hospital in Kenya. Welcome, Dr. And I wish you could present in 5 minutes.
So good evening. I know the sugars are a bit low, so I'll make it short and sweet. I'll just move very fast. So I'll be presenting on the effects of antimicrobial stewardship interventions implemented in a rural hospital in Kenya. So that rural hospital is Makueni County Referral Hospital. It is based in Lower Eastern Kenya, county number 17. Yeah, thank you for that. So a bit of an introduction. Everybody knows antimicrobial resistance, which continues to be a risk to patient safety. Actually, one of the things that I was looking at in one of the data that is there is antimicrobial resistance is actually one of the top 10 public health concerns. That is as per the World Health Organization. The number of deaths that were caused or were attributed to actually antimicrobial resistance were 255,000. That is in the year 2020, the same year that we had COVID. If you look at the numbers, that is actually almost equivalent to the total number of deaths which were actually attributed to HIV, TB, malaria combined. So you can imagine the kind of pandemic that we actually have right now. So I'll just ask one question. After I'm done with this, you can give me the answers. Normally, the questions come from you and then back. So I'll ask one question. So a patient comes, no fever, has a cough and a runny nose. Very common in a community pharmacy, and I think that is what we are doing here right now. So I'll just want people to give me like 3 answers about what you'll do in terms of management of the same. Takumbuka swali, I said short and sweet, so that's good. So the misuse and overuse of antimicrobials has been attributed as one of the main drivers for antimicrobial resistance, and that's why we did something called a point prevalence survey. So we actually need to do regular surveillance of antimicrobial utilization and stewardship interventions, which are important in assisting to assess the utilization of antimicrobials and cut the increasing growth of what? Of resistance. So this is actually a bit recent. I don't have a pointer, so I hope this will work. So new cases of antibiotic resistance gonorrhea identified in England. The main thing I want you to note is not really even the gonorrhea. I'm wondering why we have gonorrhea in this date and time. The main thing is, check the date. It's actually Monday, 7th February, 2022. Very recent. Yeah, so it's something that we actually have. It's on the ground. So something that we need to look at. So what did we do? First thing is we actually did a PPS, which was conducted in September 2021. Apologies for that. So for those who are aware of what is a PPS, that's a point prevalence survey. So normally you collect data for the patients who are inpatient, that is in the ward, who are admitted on antimicrobials by 8 a.m. on the day of the study. So we actually did that. It was actually done in the month of September 2021. So various data was actually collected on that day. We took patient demographic data and clinical data, which were taken from the patient files, the antimicrobials which they were on, and then the various biomarkers. The most common ones in a public facility will be the CRP. You have your full hemogram, and then also culture and sensitivity from the lab services. And then data analysis was done using the WHO PPS analysis tool. So the antibiotics were actually classified based on the AWARE classification, that is the access class, watch class, and the reserve class. So still on the methodology, we did our first PPS. That was in September 2021. So between September 2021 and February 2022, which was the study period, various interventions were actually done. One of the things that we actually identified was the fact that most people don't actually know what is antimicrobial stewardship. A lot of us, okay, not a lot, all of us here are pharmacists, but how many of us were actually taught about antimicrobial stewardship in campus? In campus. How many of us actually apply that in our field, qua ground? So 3 hands. Okay, so by a rough estimate, that would be like what? 5-10% of us? Yes, so you can see where we are right now. So one of the interventions that we did was actually CMEs of clinicians and nurses. So question comes, a patient comes, you want to do surgical prophylaxis before the patient goes for surgery. So, what drug do you give? How much of that drug? What is the duration of that drug that you need to give? A patient has an intra-abdominal infection. What drug do you give? How much of that drug? In case it fails, what are the susceptibility patterns that you have? Main thing, how many of us actually have labs that are empowered? You can actually do a culture and sensitivity so that, oh, you can. Nice. I need to come to your facilities. It's a good thing. We rarely actually get that. So how many of us have labs that are empowered? Second thing, which is actually very important, how many of these labs are actually linked to your pharmacy? So that they can tell you we have carbapenem resistant to this drug. And you can actually advise the clinician in regards to the same. Because most of the time what we do is we actually give prolonged antibiotics and hoping for a miracle. And there's a resistance pattern. How many of us have actually even thought about developing what? An antibiogram. Infection and prevention and control, very important. As much as you're giving your prophylaxis, if you're not doing that, you're still giving an entry to the antimicrobials. And then we also initiated antimicrobial ward rounds, which were being done twice a week during the major ward rounds, so it was a multidisciplinary thing. Capacity building of the lab in terms of training, and then antimicrobials audits were conducted in subsequent 6 months. So we did those interventions. After that, we did a second PPS in February 2022. That was the second one, because the first one we did in September 2021. So that was it. So findings. So this is just a general overview of the same. I think you can find better details of this in the global PPS website. So just an overview. The total number of patients who were seen in September 2021 was 174. In February 2022 was 184, so plus or minus the same. Then you can look at the number of adults who are there. Pediatrics also, you can see it's actually, the number of patients were actually a bit limited in regards to the same. And then the neonates. So I just gave an overall view of the same. You could see the antimicrobial prevalence. In 2021, it was 45.4%. Note that figure, because I'll talk about it in my conclusion. Then in February 2022, it actually reduced to 39.7. So you can see what is happening in Kenya. So our antimicrobial prevalence is 43%. WHO advocates for, I think, 30% of antimicrobials prescribed in any given time in a hospital. So just a breakdown of the same. So as you can see, the adult ward had a decrease in antimicrobial use. In regards to the same, in the adult medical ward, there was a decrease of 19.4%. Surgical ward, there was a decrease of 2.8%. Now, you'll realize that there's a big difference between the two. Why? We have guidelines for surgical prophylaxis, but we don't have guidelines for medical what? Management of infections. So there is a varied, antibiotic use is actually dependent on the physician, which is not right. So, because the disease patterns are actually what? Fairly similar. So one patient with the same disease should actually be standardized treatment, independent of the kind of physician who's actually treating the same. ICU, of course, we expected a high prevalence of antibiotics being ICU. They'll actually be given for prophylaxis, so that one was at 100%. So in terms of the same, the Kenyan one is 87.5, so I couldn't get the one for medical and surgical wards for the two departments. So in the pediatric wards, that was the change. To note is the surgical children ward. You'll realize that there was actually an increase in what? The antimicrobial use. But what you'll need to remember is this is not really statistically significant, because the number of pediatrics that we had initially was 20. So 20, kama waliongezeka like 3, it actually skews the data. I don't know if it makes sense. So because of the limited sample size. So that was it. And then the NBU, which had an increase of 14.9%. In terms of antimicrobial use, another place where I'd like us to look at, so there was actually a big decrease in the use of third generation cephalosporins, our ceftriaxones, then penicillins, and then you can see the other drugs which were there. Now the beauty about this, what I really like about it, is the fact that actually if you look at this, there was actually an increase in the use of aminoglycosides. There was an increase in the use of imidazole derivatives. So what does that tell us? Both of these drugs are actually in which class? Access, watch, reserve. Access, it's actually what we want. You actually want to increase your usage of what? Access, so that we use limited of watch and there is which I felt was a good thing. So in terms of conclusion, the establishment of an antimicrobial stewardship program as an intervention led to marked reduction in the antibiotic prescribing during this study period. So as a result of the MS, the use of antimicrobials actually fell down below the national average, which is 43%. Our target is actually to get to 30% as a country and also as a hospital. And then there is need to strengthen MS practices, that is antimicrobial stewardship practices, so that we can achieve the target of 30%. So as a recommendation, I said 5 minutes. I think I have one, I hope. So as a recommendation, first, I'll go back to this slide. We are all pharmacists. Our problem is our young pharmacists are not being employed. We can agree on that. And that's something that I think was highlighted when we were on the other side. So look at our cephalosporins. A busy hospital will probably use 3,000 vials of ceftriaxone in a month. True? So and it's actually one of the recommendations that we are pushing to do with REACT. You can see Dr. Tracy is here. If we can quantitatively do this and go to your facility, and after you have put these interventions, you say you are using ceftriaxone 3,000 vials, because of proper diligent use of antimicrobials, we have reduced it to 2,000. So you have actually saved 1,000 vials. How much is a vial of ceftriaxone? Depends. Give me a figure. 20 bob. It can't be 20. Okay, let's go with 50. 50 is good, eh? So the gurus have said 50. I'll go with 50. So 50 times 1,000, that is 50,000 Kenya shillings in a month for one drug. If you do that for 4 drugs, that's 200,000. Have you employed a pharmacist? Has the patient gotten the right treatment? And it's a win-win. And you've actually saved on healthcare. This money can be used somewhere else. Our policymakers actually listen to money. Go tell them about antimicrobial stewardship. They have no idea what it is. So it's actually something that I felt that probably we can share and look at. Second thing, I asked a question about fever. Nimemaliza. So, okay, no, it was not fever. I asked about a running nose. Yes, it was a running nose. So what will we do for it? Most common, we give an antibiotic. Okay, most clinicians give an antibiotic. Akona homa, that's what they do. So what would you give? To brainstorm to very quickly. Somebody running nose, no fever, with a cough. Anybody? Antihistamine, very good. What else? There's no fever, There's no indication for an antibiotic, And the problem is most of us, what we do is we actually look for a profit margin. So the idea is give them what? Give them your antihistamines, You can give a multivitamin. Is it indicated? Is it right for the patient? Is it safe for the patient? Does you as a pharmacist get a profit margin in regards to the same? So umesaidia patient na umejisaidia, Okay, sir, I'm done. Thank you.
Thank you so much, Dr. Gavin. Indeed, AMS is a pandemic. I would say it's like a pandemic because when you look at how much in terms of healthcare costs, it's quite significant. I think I was looking at data from the US, and it's in terms of billions of dollars. So this is something that needs to be addressed, and I'm glad that even WHO recognized that early enough, and there are already interventions being done. And who best to address AMS than the pharmacist? And so thank you so much for that presentation. And we are actually being requested to go back to the main hall for this some more. I think we still have some issues to be covered within the main hall. But before we do that, I would want us to take probably 2 to 3 questions. I don't know whether Dr. June Gasheri was here. We are. Dr. Viano, we can do in 5 minutes? Yeah. Okay. It's okay. So Dr. June Gasheri will be presenting on the analysis of antibiotic use patterns in community and clinical setting in urban and peri-urban Nairobi during the COVID-19 pandemic. And the other thing I would want to request, if you have a question so that we can move fast, kindly write your question and then you bring it to me so that we can be able to give the presenters for them to prepare the responses. Thank you. Dr. June, you have a senior HDMI.
Good afternoon, everybody. My name is Dr. June Kasheri. I'm taking my master's in pharmacy and MPharm in pharmacoepidemiology and pharmacovigilance in the University of Nairobi. And this project we did in collaboration with IRI, the International Livestock Research Institute, which you know about One Health. And I'm very glad that the presenter who was before me was talking about AML. So I do not have to do a lot of introduction. We all know what AMR is, and so I'm going to present to you analysis of antibiotic use patterns in community and clinical settings in Nairobi during the COVID-19 pandemic. So that is basically our background. So we all know what is AML, and I was very surprised, one of us saying that pharmacists do not know what AML is, but I really doubt whether it is a pharmacist or whether those were pharmacists. But basically AML is when a microbe, that is a fungi, a bacteria, or do not respond to an antibiotic or an antimicrobial. So we know the prevalence of antibiotic use is the main driver of AML, and antibiotic use in COVID-19 is mostly described or attributed to acquisition of secondary co-infection or resemblance of the bacteria pneumonia. So in this study, it is hypothesized that that in the community and clinical setting, there was likelihood of increased antibiotic use during the COVID-19 pandemic, but there is no such study that has been done, and that's why I thought I should fill in the gap. So on my, my left side, we can see a diagram there. Just, I know it's not clear, but it's just stressing about how COVID-19 and microbial use or antibiotic use, in this case we are talking specifically about antibiotic use, how they are related. And just below that, we have a systematic study that was conducted. We had 3,338 COVID patients, whereby they did a study, and so that about 3.5% of the patients, COVID patients, had a co-infection, 14.3% had bacteria infection. But what we see like 71.8% received antibiotics. So those patients in between, they were not supposed to receive antibiotic, but they received antibiotic. So what are we doing? We are introducing these patients to antimicrobial resistance. So basically, the study objective was to analyze the patterns of antibiotic use in the community and in the clinical setting in Nairobi. So in our study, involved two themes. We did a study in the survey in the community, that is the community pharmacies, and also in the hospital setting, whereby we did our study in the hospital setting retrospectively. We looked back during COVID. So we'll start with the community. It was a cross-sectional survey which was conducted between November to December, and we selected areas in Nairobi. Why? Because Nairobi had the highest COVID-19 patients, so we found it a study area that was good to conduct this study. And our sample size was 243 pharmacies. That is what the number of pharmacies we conducted our survey. So our questionnaire was through open data kit. Just next there, it's just that is the Nairobi map, just a distribution of the areas or the pharmacies that we covered. Those are the red dots, and that is myself just doing the survey. So in the hospital setting, we did it into two themes. In the hospital setting, we carried this study in KU, Kenyatta University Teaching Referral and Research Hospital, and Tigoni, level 4. Reason being that these are facilities that from the beginning of COVID, they were engaged in management of the COVID patients. And it was a retrospective review. We looked back into the files, the records, and this one was, we also conducted, we corrected data from the general ward or the general medical ward during the same period, that is between March 2020 and November 2021. And in the general ward, we excluded the respiratory infections. Reason being that we do not have any chance of a COVID patient in the general medical ward. So that acted as our baseline data. So I jump right into the findings. We'll start with the community findings. And we found that these in the community, those that we interviewed, that we got into the pharmacy, found someone, the higher percentage was males, but it was not significant because you can see 52 and 48%. And then the level of training, somebody was asking in our first present about the level of training, and we found that 67% are diploma holders, but we had around 26% of degree holders, those are pharmacists. So the type of business, most of it was sole proprietorship, and the reason for this question, we wanted to see whether a practice, mostly in the joint pharmacy or the chain pharmacy, the practice is usually the same because they are run by the same people. So the median age of those we interviewed was around 30 years, so we can see all these are young people. So we jump right to the customer characteristics and the prescription practices, and we found that they reported that those who interviewed, the pharmacy, the pharmtechs, that 91.3% dealt with the COVID-19 patients, which is with a mean average of around 15 patients per week. This is the first point that the patient comes even before they go to the pharmacy. So that was a very high number that they saw COVID, which was expected. And then the most common presenting symptoms were sore throat, running nose, and fever, which were corresponding to the signs and symptoms of COVID-19, and sore throat was the highest at 29%. So 44% of the presumptive COVID patients were prescribed for antibiotics, depending on the symptoms. So no test were done, just like we were being asked, if someone walked today with a cough, with a flu, what do you give? And we found that 44% of them received an antibiotic. And 97% of the pharmacists were aware that they have a critical role in AML prevention. We asked a few questions on knowledge, and so we got like 97% of those people we interviewed in the pharmacy, they know that we have a key role too in prevention of AML. However, 31% of the pharmacists or the technicians interviewed thought that antibiotics can be administered to treat viral infection. You see, this is serious because we know antibiotics are known to treat bacterial infection. But I also thought maybe this came in handy because of the COVID-19. Because a patient comes, we are hearing advertisement that give azithromycin. Maybe they thought now azithromycin is used to treat the viral infection, but that should not be the case. So moving down on, the prevalence of antibiotic use in the presumed COVID patients in the community was 74%. Hey, we can see that that number is quite high. Dr. Gavin told us it should be at least 30%, but we can see the prevalence was quite high in the community. And azithromycin was the most combined antibiotic singly, and also we found that these antibiotics were given in combination. Like you're given azithromycin and you're given augmentin or coamoxiclav. So 55% of the COVID-19 patients had a doctor's prescriptions. The core prescription of antibiotic with zinc, vitamin C, and D was noted in more than 90% of the patients. Here on my left, we have a diagram whereby you see the thicker the line, the more likelihood that combination was given. This is just a diagram showing like two drugs were combined, and we find that the line between azithromycin and coamoxiclav is thicker, which says most of the patients were given that combination. And why are we giving this combination to our COVID patients? It is a viral infection. We can also see we had azithromycin and cefuroxime. Again, cefuroxime and amoxiclav. Those were the combinations that we found that were being given in the community pharmacy. So we jump into the hospital setting. These are the findings. And basically we are able to sample out 1014 COVID patients vis-a-vis the general ward. I'm going to compare the two of them. The COVID, the general ward, we were able to get 790, and 59% were males. Vis-a-vis the general ward, we had 52%. The highest was female. So we can see like the COVID patients, the male patients were more affected by the COVID. Again, the age, the mean age for the COVID patients was 54 years, and 37 years for the general ward. The COVID confirmation, mostly the tests that were used was antigen and PCR at 51 and 47%. So most comorbidities that were found in these COVID patients was hypertension at 29% and diabetes. And if you check again in the general ward, we found 70% of the patients had no comorbidities, and 13% was for hypertension. So that was just a comparison of the demographics between the COVID ward and the general medical ward. So we go to the antibiotic use patterns, and we found that the prevalence of antibiotic use in the COVID-19 patients was 78%, a high number, right? And we have 54% in the general ward. You see, in my graph, next there we have the red color presents the COVID patients, and the black color presents the general ward. So again, in the hospital, we had the most common antibiotic for the COVID patients was azithromycin at 62%. And ceftriaxone at 36%. So we have a slight change of the antibiotic because in the community we had azithromycin and coamoxiclav. Here we've seen now ceftriaxone has set in, and also azithromycin as the highest. In the general ward, the commonly prescribed antibiotic was ceftriaxone at 21%. So you can see the difference. You can see what COVID has done to antibiotics. And then the bacterial culture was only done in 2% of the COVID patients and 4% in the general ward. Again, someone spoke about lab testing. We need to confirm what organism is causing this bacterial infection so that we can give the antibiotic. Again, we did a classification of the AWARE classification, that is according to the WHO. AWARE standing for A, access, W, watch, and R, reserve. So AWARE classification, these are the antibiotics that you're supposed to access and you're supposed to use as the first line. Then we have the watch antibiotics. They are more prone to resistance, and they should not be given as much as AWARE, and they should be the key target of antimicrobial stewardship program. So we found that the first top line, I don't know whether you can see, we have the hospital, that is the general ward. We have the COVID, and we have the community. We can see the green color represent the access drugs, which show low resistance potential. The yellow colors show the watch, and the reserve drug, which is the red color. So we can see same trends in COVID patients in the hospitals and the community. So less than 20% of the access drugs were given. But we can see the watch drugs, which should be the now first line we should look at when looking at antimicrobial stewardship, were the drugs which were used more. This is azithromycin is in the watch class, and it was used more for management of COVID-19, which is a viral infection. So we are not saying that you should not use an antibiotic in COVID patients, but in case of super infections or co-infection, that's when you should use antibiotic. But you can see our results, and we still found out there are some drugs such as meropenem, which were used for the reserve antibiotic. So I'm almost winding up, please. So we have co-use patterns. We saw this is for the hospital. We found that azithromycin and ceftriaxone were co-used together. When I talk about co-use, it does not mean that they were given at the same time, but it all depends on the duration. You might have said for a long time, you were introduced to an antibiotic, got a super infection or co-infection, then another antibiotic was used. So we found that in the hospital, the most co-used was azithromycin and amoxiclav, followed by the blue color. You see the light blue color, it's where that it shows those antibiotics that were used together. We have benzpenicillin and amoxiclav, but this was at low percentage. So, conclusion, we noted that there was high prevalence of antibiotic use in both community and clinical setting. And then most of the prescribed drugs for the COVID patients are the watch drugs. Antibiotics were commonly prescribed, the practice in the community and the hospital setting, there was no much difference. Basically, we looked out at other studies that were conducted. There was a study that was conducted in Africa, in Sierra Leone. We had another in UK. They are the same trends that we are finding. Azithromycin was shining during the COVID-19. And so there are same patterns of use that you're seeing, but it does not tell us that is they are used rationally. So what do we recommend? So urgently let us address the irrational or inappropriate use of antibiotics. Why? The increased cost of healthcare increased incidence of advanced events and eventually AML. The last slide. Then we have healthcare worker sensitization and training. I'm happy that MOH was here. We had our regulators, the PPB, and you are here as pharmacists. So we all have a role. Let us join hands. Let us work as a team to make sure that we strengthen the antimicrobial stewardship and make sure we use our antibiotics rationally. Then we have improvement of laboratory capacities so that we can be sure, yes, there is an antibacterial. Here we need to use an antibiotic. So that is the end of the slides. Thank you so much for listening, and thank you for your patience.
Thank you so much, Dr. June, for that presentation. And we can give her another round of applause. So at this point, we are pressed for time, but I want to give maybe 5 minutes for Q&A. And for those questions which were had written, I want to invite the presenters in this order. I think I want to start with the KUTRH team. And then after that, we can have Dr. Orangi.
Good afternoon again. So the question I got is that why would you spend 8 million plus on an automated dispensing cabinet in the era of AI and robotics? And another question is realization for in a hospital with a bed capacity of over 600, is it viable? Thank you so much for whoever asked these. These are brilliant questions. And so for the first questions about AI and robotics, first of all, as I pointed out in the presentation, is that we are really trying to have the system, we start making the system in our country ourselves. So first of all, this 8 million, we are really hoping it will go down from there. And I know it's a bit of a concern in terms of cost, the cost and the effectiveness, like how will it, the benefit. So we'll have to weigh that, and it's still also at an infancy stage, so we'll continue to brainstorm more. But from where I'm standing, I believe that the 8 million will go down for the by the time it will be installed in the nation. And then the AI robotics in dispensing. I don't know about you. I don't know if there is more there. Please correct me if I'm wrong. But I know robotics and AI could be even more expensive than the structure. And at the end of the day, we have to start from somewhere. We can't keep postponing and saying, let's wait for the times robotics will be in our country. I mean, countries like the USA, Spain, they're actually using this. And there are first world countries that are already using robotics. They have AI. So, and also when we are embracing technology in pharmacy, we also have to make sure and really brainstorm that we are not taking the job of a pharmacist at the end of the day. We know what AI has done in other fields, taken the jobs, made most of the workers irrelevant. So we also have to brainstorm more around this idea and make sure that we are not taking, but actually creating more jobs for pharmacists, and also while doing our works more efficiently. Then for the 650 capacity hospital, again, the cabinets are really highly tailored, like up to, for now, the data that we have, there's the maximum capacity has been up to 100. And in our setup, how we were looking at it is really using in specific wards. We're not thinking about using every ward in the hospital, although we are looking at a future like that. So we'll start again from somewhere, maybe for hospitals, for wards like the ICU and isolation. Like I told you, where it started from is the COVID issue, how we were having trouble transferring the medication and to avoid contamination. So you can start from there for the ICU hospital, for the ICU wards and isolation. Then from there we can we'll again brainstorm if it's a cost-effective idea to install this system in every ward. I don't know if I was able to cover that, but thank you.
Thank you so much, Daktari. Dr. Gavin?
So I'll be brief. So I've been asked to speak on antimicrobial ward rounds, who is involved in as a multidisciplinary team. So main people, the main players in this, you have your physician, your pharmacists, your lab technologists, and then your IPC coordinator. Most of the time you actually find it's either a public health officer or a nurse, but most of the time it's usually a nurse. Those are the main people. However, we are talking about patient safety. It will also be prudent for you to involve your nutritionist, to involve, if you have your radiology department, and these other departments which are usually in the ward. So as a pharmacist, what will you be looking for? I'm actually privileged. My mentor and supervisor is actually here, Professor Ndemo. The first thing you'd have asked us is, in pharmacy practice, is the drug indicated? So what are you looking for? Is it the right indication for that drug? Is it safe? Those are the main pertinent issues that you'd actually be looking at. What kind of pharmaceutical interventions do you make in your antimicrobial ward rounds in regards to this? So you're actually a pharmacist. You have the powers to stop the use of an antibiotic. So we're talking about irrational antibiotic use as being a main driver of AMR. So one of the things, if the antibiotic is not indicated, you actually stop. How do you know this? You check if there are any biomarkers. Does the patient have a fever? Does the condition in terms of guideline adherence mean that the patient should actually be on an antibiotic or not? What other things do you usually do? If an antibiotic is unnecessary, like what was being presented here, we have seen people getting dual antibiotics, cefuroxime and azithromycin. Does not make sense. Another thing, if a patient was on IV, you want to switch this patient from IV to oral. Why? Probably the patient can take the drug orally. And then this is a very common mistake. You need to switch this patient, if they are on third generation cephalosporin, switch them to a what? A cephalosporin. Sindio? One of the biggest mistakes we make is you switch from a cephalosporin to what? Beta-lactam antibiotic. You go from safe to augmentin. Doesn't really make sense. Doesn't really help your patient. And we're talking about AMR, doesn't really assist. De-escalation. Your patient was in ICU, was probably on a reserve antibiotic. What do? You actually need to de-escalate from a reserve to a watch, or from a watch to aware. Sindio? Is that an intervention? Yes, it's an intervention. And then you can also switch from IV to oral. Remember when you're talking about the cost implication. So the idea here is, if you have switched from IV to oral, why? Because this patient can do what? Can tolerate this drug what? Orally. You have done that. The cost of the branula, the cost of the syringe, and also the comfort to the patient and the comfort to the what? Health provider. So all that is actually incorporated in that. Thank you.
Thank you so much, Dr. Gavin. And I think we are really much pressed for time. And I want a comment from one of the trailblazers when it comes to pharmacy practice in Kenya. That is Professor Ndemo. And then after that, we are actually going to move to the plenary hall, or the main hall.
Yeah, thank you. I guess I didn't attend all the sessions, but there was the issue of the AI taking over from pharmacists. It's not very true, because what's happening as we develop pharmacy practice, because we're at its infancy right now, there'll be more time, and I'll talk about this tomorrow in my presentation, that the clinical model actually pays. The pharmacists have been stuck with the product all this time. And again, the computer is very faithful. It will actually make less mistakes. It will just do exactly what you just commanded it to do. In Walgreens, I think in the US, they have a whole center like a football field. They do everything, and then the prescription are delivered in the various pharmacies. So really, we simply readapt. And my last, not quite last comment is that the pharmacists have not fully appreciated there is a difference between a medical problem and a drug therapy problem. In other words, the physician can actually do all they want to do. They can prescribe, but managing that drug therapy to work for you is a different field. I mean, it's a different challenge. So in other words, it's a whole practice. I run a clinic myself. You wonder where I get my 60 patients. Normally, what I do, and I'll be very brief, is I explain where the gaps are. The physicians have identified and even do the full diagnosis, but to actually To actually get your drugs to work for you, you need somebody who's clinically trained, a pharmacist. You know, and then my last comment on antimicrobial, the AMR, I think who are this again? These guys from North Ireland, they have a very good model. The work is left with the pharmacist. There's no fight over. If this is the diagnosis, maybe probably after the culture sensitivity, the physicians have no role. They just is a pharmacist who are actually prescribing. Thank you.
Thank you so much, Prof. Ndebo. In fact, that was a very good wrap-up, and we really appreciate for your comments. And I think at this juncture, we want to bring this session to a closure. You have been a wonderful audience and participants, and so we are requested to go back to the plenary hall. And so God bless you. I have been your moderator, Dr. Esmond, standing in for Dr. Hilary Kagwa.